Brian, correct me if I'm wrong, about 6 out of 10 have a mental disorder diagnosis. Yet, mental health claims are some of the most misunderstood cases in the disability system simply because you cannot see it
Yeah.
physically, right? And what Social Security actually evaluates isn't the diagnosis itself, it's the limitations those conditions create in a person's ability to work. So, Brian, I know there's a lot of things that you want to say, but before we begin, I wanted to mention something important as well. Many people who become sick or injured, especially with a physical condition, they would experience changes in their mental health without realizing it. When you're out of work, when you're not feeling well, and your sense of purpose is disrupted, it is very common for things like depression or anxiety to
Right.
develop alongside the physical condition, right? So, one of the goals of this series is to help people recognize some of the indicators that mental health may be part of their overall situation. If that's
Hmm.
the case, getting evaluated and treated can be extremely important, not just for how you feel and function day to day, but also because if mental health is part of your overall health picture, properly documenting and treating it can strengthen and protect your Social Security disability claim. So, with that as a starting point, what we want to do now is build on that foundation and begin connecting this to what people are actually experiencing day to day. So, to help us guide that part of the conversation, I'm going to turn it over to you, Brian, to introduce our guest speaker for today, Mary Jean Ellis, to get it started.
Yes, 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 Justin. I look forward to that. Before we do, I just want to put up on my screen a few things here. The numbers that we were talking about, I have them around here somewhere. I don't know if you're going to be able to see this, but this is a chart from Social Security from 2023. And I don't know about the total number of disability awards or disability recipients that have a diagnosed mental health condition. But this chart right here indicates those that specifically have this as their primary diagnosis, and it's like 13.1%, according to my friend ChatGPT, breaking this all down. So it's significant. So thank you for that intro, Nadine. And got to get my show together here. So I'm excited to do this, Mary Jean. I thank you in advance for accepting this offer and the introduction from our good friend, Mr. James Mitchell Brown, who, if you're out there, shout out to you. And for the audience out there, I want you to think about this. Mary Jean is like the go-to person in the industry for disability representatives to help others like the Disability Digest and people that do this work to work with these conditions. She works at a very high level. As a matter of fact, she has authored a book, which I have up on my screen here, Mental Disorders and Social Security Disability Practice. And I put this up on the screen because I was perusing through it and like, this is all of the tactics that are covered. And I don't expect everybody out there to get into the weeds about the regulation that Mary Jean covers. So what I'm in hope for today is to take all this high level stuff that you have done and your experience in doing and bring it down to like my third grade level so that I can understand it and others can understand some of the key challenges that people face, like early signs, symptoms, and what are some of the common conditions, the treatment, what do you want to get in your medical records? Those are the things that we're going to cover today um, in doing this. So that's kind of the getting into it. And you know, what I'd like to start with is some early stage. And in all due respect, I know you're an attorney, not a doctor, but you've seen enough to this to probably comment. There are there are people I expect that are out there that may have a condition, but they don't know about it, right? So what could be like somebody walking around? And I say that because part of what we want to do is disability may not be the option. And I hope for many of you, maybe we can help you prevent it and stay working longer. But if you know some of these things in advance, right? So anything you could share with the audience, Mary Jean, about that?
About early stages,
Yeah.
um, and identifying problems. Yes. So a lot of times how it comes to me is, many people who come in and are wanting to claim disability, well, with that's a little later than what you mentioned. So let me go back. Um, People who have, let's say, pervasive sadness, not being able to enjoy things anymore, difficulty with concentration and memory, all of a sudden, or, over a little period of time, which is
Mm-hmm.
different.
Mm-hmm.
What's interesting, and right now I'm kind of focusing on depressive symptoms. Um, so you think of sadness, crying, difficulty, changes in appetite, either eating too much or eating too little, also sleeping too much, sleeping too little, difficulty getting out of bed in the morning,
Mm-hmm.
and otherwise disordered sleep. Um, but there's a lot of research about also different presentations of depressive symptoms in men. Men, a lot of times, have anger issues with depression, or irritability, which you might not associate with a mental health disorder. People sometimes have difficulty getting out of their homes. They're afraid, difficulty dealing with being in crowds or even in social situations.
Mm-hmm.
Um, Difficulty, paying attention at work. So those are some of and let's say if it's a bipolar issue, the depression symptoms I talked about just now, but the other side of bipolar is, increased activity levels, you know, being very outspoken in inappropriate situations, being
Uh-oh.
irritable and snappy, let's say
Mm-hmm.
with the supervisor, with other people, doing crazy, I shouldn't say crazy, doing inappropriate things like spending too much, um, doing dangerous things, speeding. Um, those are all some indications that there may be a mental health issue.
Yeah. That's a lot. So it's a lot of lifestyle changes, right? Lifestyle,
Right.
behavior pattern. You know, if you find yourself and you're at home and you're getting a lot of Uber Eats and you're not going out and engaging with people, right? Things like that can be a good indication. And I know from my experience in working with individuals that oftentimes there's a reluctance to go and address these things. But I'm in hopes that the message that Mary Jean has communicated will resonate with you because it could be addressed, right? I think there's got to be some value in catching it early and treating it before, it gets to the situation where you can't work, right?
Absolutely. Yeah.
Yeah, yeah. So there's a separate subset that Nadine touched on, which is let's take somebody with a chronic pain situation, maybe degenerative disc disease, and they've got some arthritis going on. Um, and that pain has caused discomfort, affected their work. So individuals like that um, are commonly, unfortunately, developing conditions. So would you speak to that audience differently to make them be aware, like, hey, if you're getting this, this could possibly happen? Am I making sense with that directive?
Yeah,
Yeah.
absolutely. That's kind of what I started to say before I changed course. Many times I'll have a new client, potential client in my office, and yeah, they have chronic back pain. That's their major impairment that they're aware of that gets in the way of their working full time. Chronic pain, other kinds of chronic conditions or an injury. And they're very, sad about the symptoms that they're experiencing. They're sad, they're upset, they're afraid of falling, they're afraid of, and further injuring themselves. They're afraid of being out in public and being vulnerable or catching another
Mhm.
illness,
Mhm.
because they're debilitated.
Mhm.
Or they're very many people have difficulty adjusting if they've already had to stop working or had to change the kind of work they always used to do. um it's a loss, and it's a grieving process, and it's very it could trigger a lot of depression.
Yeah. Yeah.
So many times, people who come in with these physical issues are not aware that those, feelings and symptoms that they have, the mental issues, are treatable and should be addressed because they're interactive. Our body is all connected, our brain and our body. So they're interconnected with our ability to heal, our ability to have restorative sleep for pain
Oh, yeah.
issues. Um, yeah.
Mm-hmm. Would it be safe to say if somebody develops back to our degenerative disc disease example that we've had here, or maybe you already have, that there's proactive steps that you can take? There's the traditional treatment, of course, but finding some way to fill that void because you are not able to have that same life event that you've had in the past. Um, Purpose is what Nadine touched on, right? And that's not easy I mean, I don't know about you, Mary Jean, you've been doing this work and you do a great job at it. But for me, in this perspective, it's like a game now. I've been doing it so long. And if I didn't have the ability to do that, I would definitely, I could see where that would be an issue. Um, and so I guess what I'm saying is find a replacement. It's something that might help, right? Yeah. Let's change gears a little bit and talk about some of the common conditions. When I put up that pie chart earlier, I extracted from that some of the major categories of conditions that are out there. And where I'm going with this is like where do these conditions show up in the workplace? So if we start with depression first, are there are there like telltale signs that you've learned over time that um, people experience?
Sure. So ability to get to work on time,
Ah,
because um, there's not the motivation. It's difficult to get out of bed in the morning. For some people, just getting in the shower and getting dressed is exhausting and um, sort of insurmountable. Just doing regular day-to-day activities with depression. Um, not being able to focus and concentrate at one's job, having difficulty with memory, having, of course, when one is confronted or, you know, talked to by a supervisor, about doing something new, about learning a new skill, being overwhelmed with, the idea of doing something different or learning something new.
Hmm.
Those are some of the things that I see with depression.
Tell you, I've got some friends of mine that don't show up on time, and I'm going to start telling them to show up on time because it's depressing. It is for me when they're late. Maybe it'll have some type of positive effect on them. I've tried everything. They're great people, and there's two of them, but they are who they are. So that's interesting. Is there a difference between the other common conditions like I'll move on to anxiety. So does anxiety have other telltale signs that people should be aware of, or are they common with depression?
Well, there's some that are uncommon. They're, in my experience, the difficulty paying attention, difficulty with memory for
Mm-hmm.
new things, new procedures and things at work, or remembering to do, routine things. But anxiety also um, could be, you know, being having a lot of anticipatory anxiety, anticipatory fear about, public speaking, about giving a presentation, about even talking to people, and
Mm-hmm.
participating in a meeting at work.
Mm-hmm. Mm-hmm.
Some people have panic attacks or panic disorder, and that uh, certain things or could trigger panic, or in some people it just comes out of nowhere, and those symptoms are very debilitating. They, people think they're going to die, they think they're going to have a heart attack, eh, you know um with their they have chest pain sometimes, shortness of breath. They could even black out or almost black out. And I've
Mm.
had clients who have gone to the ER from work with panic attacks.
I'm just thinking
Um,
about hearings. I mean, if you've had clients go to hearing, and this is a large part, maybe all of your work is mental health, right? I mean, I would expect going to a hearing, maybe not so much if it's a telephone one, but a physical hearing could be a real driver. Uh, yeah,
sure. Although a lot of times I tell my clients, don't worry about it if it happens, because then the judge sees you having a panic
yeah,
attack.
true, true. And they wouldn't do that on the phone, right? That's tough or more difficult. I don't see, right? Because the visual component is gone. Interesting. Huh. Um, would bipolar be considered another major condition with specific signs?
Well, yeah, bipolar we see a lot. And there's a lot of research both ways, whether it's being underdiagnosed or overdiagnosed. Um, but yeah, a lot of people that we see in the office do have bipolar disorder. Some people, and also, I should say, with depression, anxiety, and bipolar, certainly there are many, many people out in the workforce that are taking care of themselves. They're medicated in a lot of cases, they're going to therapy, and they're very functional. Or they're functional for years at a time. But for some people, there comes a time when the symptoms are debilitating.
Hmm.
So bipolar, the difference between, of course, the depression and the bipolar is, with the bipolar, you also have at times extreme irritability, as well as with some people, whether it's bipolar 1 or bipolar 2, full blown manic, um, episodes where the person is doing dangerous things, speeding, spending too much money, maybe stealing from work, God forbid, um, doing very inappropriate things, road rage, those sorts of things. So that's where we see, that's
Mm-hmm.
what we see in bipolar symptoms.
Mm-hmm. All right. So we've covered three major conditions, right? Are there any others that are worthy of putting into this category? You think we've covered the major ones?
Yes, I think we've covered the major ones. Less often we see psychotic disorders and people who hear things that aren't there. Sometimes the symptoms are rather subtle. They hear things that aren't there. They kind of know that other people are not hearing those things. They see things that are not there. Um, they have the sense that people are plotting against them and, the world is stacked against them. Um, those people tend to, have treatment, although sometimes they don't because they don't have the insight
Mm-hmm.
to know that they're ill.
Mm-hmm.
And those are difficult cases
Mm-hmm.
when you have, try to convince the person that they have a problem.
Yeah.
Um, I think the other, and I don't know if this is outside the scope of what you want to talk about today, Brian, but substance use disorders are also huge, and they're part of mental health disorders. And the scope of mental health disorders, of course, they're very tricky because if Social Security thinks or judges that the person that's their main problem. And if they stopped using the substance, they would be able to work. They're not eligible for benefits,
Yeah.
unfortunately.
Yeah.
Even though I certainly have a lot of sympathy and compassion for people with substance use disorders. Um, and I don't I don't turn them away right away if they come to me. I want to try to develop their other problems to convince Social Security that there are other reasons that they can't work.
Yeah. Yeah, that's a really good point, and this definitely falls into the scope of what we're doing. And if you're listening out there live or to the replay, and you're like, "Oh my gosh, you know what? I could really connect with Mary Jean." I'll give you some directions at the end of the show where you can reach out and get in touch, get evaluated. Because it's situations like that where your expertise will definitely be of value to people. Um, so that's a kind of a segue into my next thought here, which is for people that are out there and, maybe you have a condition and it's not diagnosed or it's diagnosed and you're not getting treated. Can you like zero in on the importance for somebody with any of these conditions, anxiety, depression, bipolar, to get like why they should get a professional evaluation just rather than assuming like, I don't know, I don't think I have anything, or I know I've got it, but I've got it under control and I don't need treatment.
Well, we always say to clients or potential clients, um, first of all, take care of yourself. It's good for you if you get any treatment you need for any, condition you have. So, a person who's, overwhelmed with fear about different situations or leaving their house, etc., you'll feel better if you get probably, most people can be treated well, treated effectively. Get some help, start with your primary. Although usually going to the primary is not enough. Certainly, if you want to prove your claim, even if it's in part a mental health disorder, Social Security is going to take your claim much more seriously if you see a specialist. And another technicality with Social Security is you need to see, to just establish that you have a mental health disorder, you need to see what's called a acceptable medical source. So certain people with certain credentials are allowed by Social Security's rules to establish a mental health disorder. And those kind of people or professionals would include medical doctors, osteopaths, and lately, which is really important, it's been added, advanced practice nurses.
Okay.
And if you can, talk to your PCP, your primary, to get a referral or a suggestion of who to see, whether it's a psychiatrist or a psychiatric nurse practitioner or a PhD credentialed therapist or psychologist. Those are all acceptable medical sources. Then once you have established your condition, if you're trying to prove that you're disabled for Social Security disability benefits, seeing, which is also really helpful for your own, being, your own well-being,
Right.
as well as proving your limitations to Social Security. You can see, a social worker, a therapist, someone who's not necessarily a so-called acceptable medical source, but Social Security will take those records into account that, first of all, you're seeking treatment to get better, which is important for Social Security,
Right.
that you're doing everything you can to get better, and you're following, your provider's recommendations, as well as that those people can document your limitations, your difficulties with communication, with concentration, with getting out of the house, doing your self-care, those sorts of things.
Good points. For those of you listening out there and thinking, well, you know what? Maybe you're still working, or you know somebody that's working and has a condition like this. I want you to take what you have just learned from Mary Jean and then back it up into a work environment. Let's say somebody is still working. They have early signs, whether they know it or they don't know it. The value of doing this there, and this is my opinion, is that it could keep you working longer, which is ideal. You definitely working is better than, in my opinion, being a Social Security disability recipient, just my opinion. So one, it can help you there. But if you unfortunately get to the point where you are out of work, you're starting, as Mary Jean just indicated, you've built a record. So you have the financial piece where you can keep doing what you're doing. And as you phase out, we just had people recently still working, have been doing the doctoring and what has been mentioned here, but that's allowed them to get some accommodations at work so they can continue to work longer. So there's value not just for disability applicants here, for others is what we're attempting to reach out. That's my gesture, reaching out. So this is really good. Okay, so you have the treatment in place. What kinds of things or statements, or what should people be telling the doctors that maybe they don't know about or they don't mention when it comes to their condition and how it's affecting their work?
Yeah, that's important. So the record for, once you get to a Social Security disability process, if unfortunately you're unable to keep working full time, the records, what you tell the what you tell the provider, doesn't matter so much. It's what ends up in the records. So,
That's
but
important.
when
Sorry to interrupt you, but I hope, would you just repeat that? I'm just trying to drill this home with people. This is beautiful.
you need evidence. So the evidence is what ends up in the notes. You may even want to say, well, one thing you don't want to do, probably, especially with a new provider, if you start seeing, let's say, a psychiatrist, you don't want to go in there leading off with, first of all, never tell them my attorney sent me here, or I'm here because I want to bolster my Social Security disability case. Don't say that, because it'll end up in the records, and probably, and the provider will feel like a hired gun. And it's not a good it's not a good look for the provider. They're not there to be a hired gun for the most part. Uh, Rarely, I would say, unless you're there for a one-time opinion. You could, you know, go there for a one-time opinion, and that's okay then to say that. Um, don't say reflexively when the provider asks you how you're doing, don't say fine, period. Because that ends up in the records a lot of times. I mean, I'm not telling you to lie or exaggerate, but what I'm suggesting is, if you had a rough week, don't say fine. Tell the provider what you're going through. Tell them your symptoms. If you're an up and down, if your symptoms go up and down, which in many cases they do, not only bipolar, but
Mm,
in any condition, people have good and bad days. They have episodes of, depression or anxiety, or certainly panic attacks. And you're having a really good day. You could say, hey, I'm having a good day, but last week was a nightmare. Um, don't just say fine. Unless that's the case. Um, One thing I like to recommend to clients is to keep, and you can get these online if you Google this, symptom diaries for your particular illness. So there are out there panic disorder diaries where every day it's like a calendar with little boxes, and every day you're going to be writing down, did I have a panic attack? If so, how many? How long did they last? Was I
right.
able to function?
Mm-hmm. Mm-hmm.
Um, I'm trying to think of other examples. Probably with bipolar, you can also, if you're up and down with different types of episodes, keep a diary. And it doesn't even have to be a formal diary, it could just be your notes about what's going on. And give them to your provider to make them part of your record, your medical records.
Mm-hmm.
And that could be super helpful. And it could help with your treatment as well.
Mm-hmm.
It could help the provider, understand where you're coming from.
Mm-hmm.
The other suggestion I like to make is, don't tell your provider um, that you, if you can, that you really are hurting for money and that's why you're looking for
Oh,
disability.
yeah.
Um, I've had
That's tough.
psychiatrist notes that have said that, my patient looking for the disability lifestyle and would rather be on a beach than working. Oh my God. That sank their person's case.
Mm.
Um, of course, I don't think, probably, well, I think that particular doctor was biased, and maybe what the patient said, didn't make that much of a difference, but maybe they brought up, financial need.
Mm-hmm.
So those are
Well,
some of my thoughts.
it needs to be addressed delicately. Most people apply for disability benefits because of the financial stability it provides. But, your points are definitely valid, and, you need to address it in the right way. So I want to stay on this for treatment because um, and I've been doing this. I don't know how long you've been doing this work, but it's coming up on 20 years, and it's still the same educational process for people that enter this unfortunate disability approval process where they have an understanding that they just go to the doctors and that's all they need to do. Right. So, what advice could you share in addition to what you already have about just going to the doctors and leaving and then thinking everything is going to take care of itself, especially with these conditions? As Nadine mentioned, they're invisible. It's not like there's imaging for degenerative disc disease or some other condition that you can really see. You have to advocate for yourself. So,
Mhm. Compliance with doctors or providers' recommendations is super important. So, first of all, if you're going, which a lot of people start out by going to their primary care provider and saying, "Hey, I feel depressed. I feel sad. I can't function, or I'm very, very anxious. Can you prescribe something?" And many PCPs will. And that's probably appropriate in with relatively minor mental health cases. But when the cases are more severe, particularly, let's say, what the PCP is prescribing doesn't really help or doesn't help enough, um, what you want to do, and if the provider doesn't do this, is ask for a referral to a specialist, a psychiatrist or a psychiatric nurse practitioner who is much more skilled and experienced in prescribing psychiatric medication. Now, not everybody wants to take psychiatric medication. If it's prescribed for you or recommended, it's better to try it if you can. But Social Security's rules do take into account that some people have particular reasons and legitimate reasons why, or even if they're not legitimate, why they won't take medication. They're afraid of or they have side effects, or they're afraid of side effects. They're very sensitive to most medications. If there are interactions, of course, they can't take them. Some people, like I said, particularly people with psychotic disorders, don't think they need medication, either all the time or part of the time.
mhm.
Um, those are reasons why that or they can't afford medication. Some of those reasons Social Security will take into account and as an excuse for noncompliance with doctors' recommendations. If the provider is advocating the patient goes into, let's say, well, first of all, therapy, psychotherapy, please give it a try because it'll help you, probably. Usually it helps. I mean, there's a lot of studies that say that medication alone won't do it. There need to be some behavioral changes or at least insight discussing with someone professional what's going on and how to make changes in one's life.
Mhm. Mhm.
Now, there are sometimes recommendations as well that person, might have to go to the hospital if they don't do something more than regular outpatient therapy. And there are programs like intensive outpatient IOP, where they're going, or what's called, I think, acute partial hospitalization, where the person is going to a more structured program, outpatient, several times a week, several hours at a time. If that's recommended, please consider giving that a try if you can. If you don't have childcare issues, if it's covered by insurance, if you can. So those are some of the suggestions I have for treatment.
So I'm hearing compliance. Do everything possible that has been prescribed to you. And if there's something that is not like doesn't work for you, you need to address that with your doctor. So compliance is big. So what about uh, this area of a conversation? Somebody is in their doctor's office, and all the compliance thing is one thing, but are there actual phrases or things that you suggest that people should say about how their condition, despite the fact that it's diagnosed and being treated, how it's impacting their ability to work or inability to work or other aspects of their lifestyle? Are there examples of that you can help people understand that? Because in my take, this is getting down to getting the goods in the medical record, right?
Yeah. Yeah, so important because, you know, if you hire an attorney or a non-attorney advocate to help you with the Social Security disability claim, usually what they'll do is they'll get the medical records, which the office notes, which are as we call them, the meat and potatoes of the case. They're the required, the requirements, the required evidence. But an advocate will also usually ask for the provider to provide some opinion evidence, either by filling out a questionnaire that's provided by the advocate or by writing a narrative with opinions of that person's functioning. Now, Social Security is going to look for specifics. So it's never enough that the provider says, my patient can't work, in my opinion, or my patient is completely disabled. That just doesn't get you anywhere with Social Security. And what Social Security is looking for is, can the person concentrate? Can the person remember simple instructions? Can they show up to work every day? Can they stay at work for 8 hours or whatever the whole shift is? Can they get there on time? Can they attend regularly? And a lot of others. Can they get along with people? Can they take directions from supervisors appropriately? Um, all of those kind of things. However, if you can get an opinion statement from a doctor or provider, but Social Security will look at the medical records that they already got, the office notes, and they may say, hey, they're inconsistent. The provider didn't say any of this stuff in the
Yeah.
office notes. So it's important when you're in the appointment to say specifically, hey, I was at work this week. I got in a fight with my supervisor because I was irritable. I have trouble concentrating. Here's an example. Try to get those details. Try to talk to your provider about the details. You want those in your medical evidence.
Beautiful. That's great. Yeah, because I think you've checked every box on that. Just going to the doctor is not enough. So in a few moments here, we're going to get into a Q&A, and Nadine and Philip will take over. But before we do, I have one last question I want to just run by you on this. In looking and you can pass if this is a difficult one and you don't have anything for it. But is there like one piece of advice, like one parting piece of advice that you'd tighten all this up with, Mary Jean, for people that are listening out there? The one takeaway?
I would say the one takeaway is get evaluated if you by a mental health professional. If any of these symptoms that we've discussed today, ring true for you, and you're not getting mental health treatment, be open to seeking something. If you're bothered at all by any of these kind of symptoms, and if you are already getting, let's say, medication from a primary, ask the primary, and it's not enough, particularly. Ask the, because you're struggling at work and in your daily life, ask the primary to send you to a specialist. I
Mm-hmm.
think those are the most important things I would say.
Right. Great. Thank you for that. And before we get into Q&A, I just, for the audience that's out there, off camera, I have learned from Mary Jean that you worked with different mental health conditions at different ages, and you've dealt with some super complicated cases. So if anybody out there feels that you would be a good fit for Mary Jean, when you are a member at the Disability Digest, if you're not, come join us. There's no cost. You get to speak to one of our amazing advocates. There's two of them here today. Would you kindly raise your hand? And just say, listen, I'd like to be able to speak with Mary Jean, and they'll ask you a few questions, make sure everything qualifies, and make the introduction. But not only will they do that, they'll provide you with our disability approval course. So if you are thinking about going through the process or going through it, you'll have that set of tools to work with Mary Jean, or if you do, or if you don't, you'll still have that. So that's the process. Okay, this has been wonderful. Ready for some Q&A, Mary Jean?
Sure.
All right, let's do it. Nadine, you want to run the show?
Yeah, sure. But I'd like to start off with giving the spotlight to Philip because I think he has some questions from his group.
Beautiful.
And while Philip is asking his questions, I'll also be posting the link right now for those of you who wants to join us live for the Q&A. Great, Philip, take it away.
All right. Wait. Yep, I got everything on. First of all, thank you, Mary Jean, for being with us today and sharing your experience with this. Excuse me. All right, first from my group says, what if my symptoms vary from day to day? How does Social Security evaluate that?
Good question. So, one thing you might want to consider is doing that, finding one online, a symptom diary, and starting to make notes of how those symptoms affect you from day to day, or whether they affect you each day, and how severe they are. Social Security's rules say that it's called the medical listings, how they look at each disorder. And they do recognize that mental health symptoms tend to wax and wane in many cases. So just because you have a couple of good days doesn't mean for Social Security purposes that you can sustain what's called, a regular job dated, 8 hours a day, 5 days a week, week in and week out. If you're missing days, or you have to go home early, a bunch of days a month, Social Security will say, hopefully, if they're being fair and applying the rules, that you can't sustain a full-time job.
Right.
Right. All right. And it's probably good if they document that along the way. Dates, myths.
Absolutely.
Yeah. All right. Next one says, what are some of the common red flags in a mental health case that can lead to a denial?
Ooh. Non-compliance, not doing what your provider recommends, not getting specialty treatment. Social Security will say that, it can't be that bad if they're only seeing a primary care physician or provider. Also, many people have symptoms and they suck it. They say, I'm sucking it up and I'm pushing through and I don't want to see somebody. Or I tried it once and it didn't help me and I didn't like the provider. Those people, their cases from a mental health point of view are doomed if mental health is big part of your case and you're not getting any treatment. I mean, Social Security will send you usually, if you're not getting treatment, to what's called a consultative examination, a one-time examination by their doctor, and you may get a diagnosis from that. But many times Social Security will say, yeah, but person doesn't need treatment, so it's not severe.
Okay. Some of this may be a little redundant, but they're asking. So, how does Social Security evaluate credibility in a mental health claim?
Ooh. So, credibility is an interesting word to use, because Social Security recently, meaning in the last few years, struck credibility determination from their rules. So, in other words, particularly judges, when it gets to judges, if you lose your claim at the lower levels, judges are not allowed to assess someone's credibility because Social Security says they're not in the business of judging character. So, from a character standpoint, they're not allowed to look at credibility. Now, do they actually do that anyway? Yeah, I think so. What they say is if your complaints are inconsistent and you don't establish waxing and waning. I mean, they could be inconsistent because they wax and wane the symptoms, right? So, but if the person says, hey, I socialize, several times a month or a week, and yet I'm saying that I'm terrified of, I have social anxiety, and I'm terrified of, being with people. You have to be able to explain how you're able to do that. So inconsistency is one thing. Unfortunately, with a lot of people who have substance problems, they they're either lying or they're not aware that they're using. And they say, I've had this happen. They say in court to the judge or in the hearing office to the judge, I've been sober for 3 years, and yet, there are, very recent positive drug tests. That's of course a credibility killer. And I'm trying to think of other examples, but mostly it's inconsistency between the activities that a person is saying they do versus their complaints to their doctor and to Social Security.
All right. I have a question myself. following in the lines of the credibility, does past work history fall into that credibility? I mean, as far as Social Security looking to see, if you have a long history of working.
Actually, that it falls under some advocates, it falls under the change in the rule in credibility determination. Some advocates say that judges are not allowed to take that into account, a solid work history in the past before one alleges they became disabled. Because I always used to bring that up to the judge, particularly, hey, this person has had a great work history. Why would they claim they're disabled unless they really can't work? But do I think Social Security looks at that favorably? Yeah, I think they still do, because people who work at Social Security are human beings, and I think they take that into account. So
Yeah.
kind of cuts both ways.
All right. It says, what role do missed appointments or gaps in treatment play in a mental health case?
Well, that's another one that cuts both ways. So it kind of depends on why the person is not attending appointments. If they're not attending appointments because they can't afford to get there, they have unreliable transportation, they're too panicked to leave the house if they're in person, visits, those help. That kind of, it doesn't help the person get treatment, but it helps establish for Social Security purposes that they're impaired. They're having a lot of difficulty. And if they can't even get to their doctor, their life-saving appointments, how the heck are they going to get to work on a regular basis? On the other hand, if they just blow off the appointments, that's a non-compliance issue, and that counts against you.
Okay. In consideration of your time, this is going to be the last one from my group today. It says, how detailed do medical records need to be when it comes to mental health symptoms and limitations?
So this could be a problem. The more detailed, the better. Some, let's say, therapists will just write down the content of all the discussion. The person's not getting along with their family, they're going to Europe, they're blah, blah, blah. Those are not so helpful usually. But I don't think people have control over what their therapist writes. Some therapists are very protective of their patients and don't even want to provide records, even though I think there's a good argument that they have to. Although, again, Social Security has a regulation that says that when you sign a release form for your records, there's an exception that therapists do not have to release the part of the record with that, the back and forth, how they're doing and all that. They only have to release, like a mental status evaluation, whether they can pay attention and whether they're, oriented to time, place, and person. If it's a psychiatrist or, prescribing provider, the date and time of the meeting, what their prescription is, the diagnosis, that sort of thing. But certainly the more detailed the records, the better. And like I may have mentioned, if those records have limitations in them, that's very helpful. Functional, problems. And let me just say that unfortunately, a lot of providers will say memory fine, concentration fine,
Yeah.
um,
Great.
oriented. They look clean and well dressed and not so helpful.
Yeah. All right, that was it for group today. And again, thank you, Mary Jean, for being here today.
Oh, you're welcome. Thanks for asking me.
We'll pass the baton on over to Nadine.
All right. Thank you so much, Phil, for asking those questions from your group. And Mary Jean, thank you so much for all of your insight. Those are really helpful, not just to our audience, but also to us who are talking to our members every day. Thank you so much. Now, I do have a couple of questions here from our chat, but we have Danny and another participant waiting in the Zoom room. So I'm going to let Danny in first. Hi, Danny.
Good day, Danny. Danny.
Hey, how
Danny
are
or
you?
Danny? Hi, is it Danny or Danny?
Danny.
Okay.
Hi.
Yeah, how can we help?
I was just wondering, I'm 100% P&T disabled by the Veterans Affairs. I mean, I still work, but I am so drained that I can't keep doing it.
So what is the one wonder that you have? Like, what are your options type question?
Yes.
All right. Drained sounds like it might fall into your category, Mary Jean.
Sure. Sounds like maybe depression. I mean, if you want to answer in this forum, are you getting any mental health treatment?
Yes, ma'am.
Okay, that's good. Good for you. Of course, for your health. Um, so if you come to the point where, unfortunately, I hope it doesn't happen, but you're unable to continue working because of how you're feeling, or you're unable to, for Social Security purposes, they consider that you're able to support yourself if you're making, believe it or not, it's a low number, $1,690 a month,
Mhm.
$1,690 a month gross. If you're unable to make that much money because of your mental condition and your other conditions combined, you may want to apply for Social Security disability.
Yeah. May I ask a question?
Yes, sir.
What kind of work are you doing?
I drive a truck.
All right. So, do you drive a truck because you like driving a truck, or is you doing it for money?
And that's what I've did for ever since the military.
All right. All right. Yeah, I mean, just a thought for you. You already have your VA 100% P&T income, right? If you look at your Social Security number that you get, and you go through the approval process and get approved, then if work is something that you would like to continue to do, once you're approved, you can return to work at a reduced amount. Like it's, ideal to stay at $1,000 or under and still do some work. But from your health perspective, it sounds like it's really taken a toll on you. That's part of the evaluation process that I'd suggest that you consider is, if it's not good for you, but you like to work, maybe the amount of work.
Yeah, but I suffer from migraines, severe sleep apnea,
Yep.
tinnitus.
Yep.
Do you, do you do you have to quit your job before you apply for it?
Well, that's $1 million question. So Mary Jean read you the regulation, but this is my opinion. Maybe you have a different one. It's really difficult to get cases approved if you're showing earned income, just generally. Even if it's in the hobby level of like $400 a month, it's just because your argument with Social Security is that I'm not able to work. That's why I'm applying. There's a lot of variables, your age and your condition, your diagnosis and your medical records and all of that. But that's just a very general statement. Do you have a different opinion, Mary Jean?
Well, we do, if somebody wants to work, I feel like it's an ethical obligation to not say to them, you need to stop working.
Yeah.
I think it's an ethical obligation on my part, and what's usually better for the person to say, listen, if you think you can work, if your doctor doesn't forbid it, doesn't say it's harmful to you, do what you can. And we do not turn away people who are working. It is like Brian said, it's harder to win those cases. And it's tricky because there are a lot of different rules about how
Yeah.
much money you can make. But if it's close to full time, even if you're making under that $16.90 a month, if it's close to full time, if it's demanding, if it's heavy work, Social Security is going to say, hey, why can't you do something later or easier full time? If you can do this kind of work, why can't you do something else? But Danny, one of the thoughts I had was, you're having trouble with the truck driving job. Maybe you can find something else that suits you better. I know that's the only work that you've ever done, but that's another option to think about.
Yeah.
Yeah, but I can't stand to be around people.
Oh,
Mm.
I think you're starting to answer your own questions. Yeah. Yeah. Mm-hmm. Well, if you're still in the working process, one of the things I would encourage you to do is we'd be glad to help you and guide you and help you understand your options. If you're not a member here at the Disability Digest, I'd encourage you to join. And there's no charge, and you can speak to one of the advocates and learn more about your situation and point you in the right direction. Do some planning. Maybe you want to work for another 4, 5, 6 months. I don't know what the deal is, but that would be my suggested next step.
All right. Well, I sure appreciate it.
All right, Danny. Hey, thank you for joining. Keep in touch with us.
Thank you, Dan.
All right. Thank you all.
Yep.
Thanks,
Take care.
Danny. All right. So there are questions I'd like to cover here from the chat. First question is from Zippy. Um, question goes like this. I've been on SSDI since 2022. I'm getting depressed and down. I miss my work. Now I'm mostly all alone. Can't be much. I have pain daily, nonstop. Should I see a psychiatrist? I also have memory issues and can't concentrate. So
it
already a
wouldn't,
recipient.
right. Wouldn't hurt.
Mhm.
Yeah.
I think it can only help, I think.
Yeah. Would it be safe to say the compliance statement that that we just went through applies for those that are approved, like Zippy?
Absolutely. Yeah, you need to continue seeing, unless one of your conditions improved a whole lot, that it's not bothering you anymore. If you're going to continue receiving benefits, you really need to keep seeing doctors, keep complying with recommendations and do whatever you can to feel better. But you will be reviewed at some point by Social Security. Most people will be reviewed every 5 years, give or take. And what we recommend is keep gathering, and it's easier these days with portals. Keep gathering your medical records so that when you are reviewed, when they send you that form, that scary form that says, hey, are you still seeing doctors? Did you go back to work? You can then hit them with paper, hit Social Security with all your medical records of the treatment you've had since you were approved. So they can see that you continue to be disabled if that's the case. Of course, if you do go back to work, you need to tell Social Security so that they're not paying you when they shouldn't be, and you're not hit with a big overpayment that you have to pay back Social Security.
Right.
Okay, thanks for that. We have another question here from Rick Watson. I'm taking meds for anxiety and depression, which is in my records and reason for rep, but I'm in pain management, which includes opioids, along with other controlled medicine, which keep me under influence. Will that affect my CDR?
No, it shouldn't. If you're taking narcotics, let's say, because they're prescribed, if you're not abusing them, if you're not doctor shopping to get more or, different than you should be, if you're not going to the ER, to get medications, if you're keeping your nose clean, so to speak, and taking them as prescribed, no, it's not going to affect your case. As a matter of fact, Social Security is going to take your pain more seriously if you have to be on heavy duty medications.
Good questions.
All right, another one. Hello, everyone. I may have misophonia. I dislike when people talking or lip smacking, etc. Can I get a disability for this disease? I'm not sure with the question. But are you guys
Well,
familiar with misophonia? I haven't heard of that.
I actually have heard of that. I don't think it's that common. I would say probably if that's your only medical issue, probably you're not going to be found eligible for Social Security disability. However, everything, the diagnosis itself does never tells the whole story and never is the thing that makes you win or lose. It's how it affects you. So if it's so debilitating that you can't stand being around other people, let's say at a workplace, there are except what Danny was saying with the truck driving, there's pretty few jobs that are available in significant numbers in the national economy, which is what Social Security looks at, that you're going to be entirely alone. So it all depends on how debilitating and what what practical functional limitations that condition causes.
Yeah, thanks for bringing that up because that's always something that Brian would advocate. Like, it's not the condition, not the diagnosis, but how your condition affects your ability to work. So that's what we wanted to prove. Okay, we have a question from Susan. If alcoholism and drug abuse are considered diseases, and with drug abuse, you get substance abuse, of course. So how can Social Security not deem that a viable reason for a disability?
Ooh, that's a good one.
That
Yeah.
is a good one. Well, in my personal opinion, that is discrimination. But unfortunately, we have to work within the law as it exists with Social Security. So I do think it's discrimination because, yes, I think, and the American Medical Association says that the substance use disorders are diseases, medical diseases, and the person can't help it. Social Security has a long history. There was a time back, I think before the 70s, when they did pay people who had only substance use disorders. But under Ronald Reagan, there was a big backlash about that. The laws changed, and they changed back and forth a little bit. But basically, Social Security's thinking is, if an administration can think, but the thinking is that they don't want to pay somebody who's then going to take that money and buy drugs or alcohol. So it's considered, I think, sort of a self-protective
Right.
idea.
Yeah.
However, like I said previously, if there are any other conditions, so what I say when somebody has a substance use disorder, a lot of times they're not taking care of their other problems. Even if it's a history of substance use disorder and it doesn't continue, that's another story. So person could be eligible if they have other conditions. But if it's a current use situation, then what I say is, please go to your primary or establish with a primary. See what else going on in your body. A lot of times people with substance use disorders don't take care of themselves. They don't realize maybe it's a secondary condition. Maybe they're self-medicating for voices in their heads or anxiety, depression. Get those other problems evaluated, get some treatment. Maybe that'll help you get off the substance, and you could possibly win your case by proving that these other issues are really the reason that you can't work.
Yeah. We have another question here. It says, does SSA or SSDI place any weight on the inherent mental strain or depression that comes with ailments such as isolation, or is an actual diagnosis needed in these cases?
Hmm.
So if I understand the question, symptoms alone will not win a case. There has to be a medical evaluation that the symptoms are coming from a condition, a diagnosed condition. So, yeah, symptoms alone are not going to do it.
Okay. I have one last question here for you, Mary Jean. What should someone be telling their provider about their condition, and how does that translate into what Social Security is actually looking for in their medical records to determine if they can or cannot work?
Ooh.
One thing people can do if they're so inclined to read through some pretty wordy stuff is go on Social Security's website, which is actually very easy to use, ssa.gov, and Google or do a search for the Blue Book. The Blue Book has what's called the listings, the medical listings for Social Security conditions. And in that, they explain in great detail what they're looking for in the medical evidence to prove, not only that the person has these disorders, the most common ones, like we discussed, depression, anxiety, bipolar, personality disorders, I mean, all of them. There are specific lists. Yeah, there you go. Specific criteria for each disorder, like, disturbance in mood, blah, blah, blah. But in the beginning part of the listing, yeah, it's 12.0. In the beginning part of the listing for mental disorders, they'll have some general language, yeah, on what Social Security's looking for. And they'll explain, it explains in great details. You can see here what kind of things they're looking for each, general category of mental disorder. So that's one thing. The other thing is, yeah, you want to explain to the provider in detail the symptoms that you're experiencing. It's not your job, I think, when you're with a provider or when you're talking to, let's say, a judge for Social Security, it's not your job to diagnose yourself. What your job is to explain how these disorders are affecting you, what your symptoms are.
Yeah. So just to kind of tighten up everything here, this is just one section under neurocognitive disorders characterized by significant decline. I'm paraphrasing, but just to kind of wrap everything up, which actually is what we're doing here, if you were just go and get your treatment and leave, and then the only thing that's going to be in your medical records is, unfortunately, I'm fine, as we talked about, which you don't want, and just your doctor's note. So if you're not communicating the limitations and how this is impacting your work and your behavior and all of that, as you've learned throughout this show, then it isn't going to comply with what Social Security is looking for. That's a great way to kind of tighten everything up here. So, yeah. On that note, Philip, Nadine, thank you for your contributions and the questions. And Mary Jean, this has been amazing, a fantastic event. I hope the 305 people that are out there watching at this time have enjoyed the show. I know many more will watch on the replay, and I thank you for doing this. And one last thing, again, as a reminder for those of you, we invite you to become a member if you're not already at the Disability Digest. Become a member. It's no charge, and we'll e-how you through the process of getting and keeping your benefits. If Mary Jean and what you heard today, is she's somebody you'd like to speak with, just ask one of the advocates. Once again, they'll raise their hands, and they'll set you up with the course and an introduction. So we look forward to having you back for our next event. This was amazing.
Thank you. Thank you so much. It was a pleasure.
And a shout out to the questions out there. I don't know. I thought they were really good today, right?
Yeah.
So,
Yeah.
yeah, excellent. So, all right, everybody, make it a great day. We'll be back here with another live in 2 weeks. God bless everybody. Stay safe.
Keep going.
Make it a great day.
Bye-bye.